Hello, this is Rick Boddy. I'm the Chief Investigator for the PRESTO study, and this is a quick video just to talk you through how to interpret an ECG for acute ischemia. So one of the things about the PRESTO study is that we're looking at two risk scores to try and decide if there are patients who are sufficiently low risk that we can leave them at home when they have suspected cardiac chest pain. We know that we can't do that using just our clinical judgment, so we need to use a risk score, and we probably need to use a troponin test, and that's what we're going to evaluate in the PRESTO study. But we know that even with a troponin test and an ECG, we can't actually leave all the patients at home. We've got to use a risk score as well, and that's where the Tmax and heart risk scores come in. An important part of both of those risk scores is that we need to interpret the ECG to see if there are signs of acute ischemia on the ECG. So in Tmax, we're asked to decide if the ECG shows acute ischemia or not. It's just a simple yes or no answer. And in the heart score, we're asked to interpret whether there's ST depression on the ECG, whether there's T-wave inversion on the ECG, or whether the ECG is normal. Now, I think in most places, paramedics are very used to interpreting ECGs for ST elevation and diagnosing STEMI, taking people to the cath lab, but not necessarily always for looking for signs of acute ischemia. So in this quick training video, I'm just going to talk through how we look for signs of ischemia on the ECG. So we'll start off, it's all based on cases in this webinar. And we're going to start off with a case here. This is a 12-lead ECG from a patient. And what you'll notice about this ECG is that it's completely normal. And the reason I put this up is because it allows us to just take a moment to recognize the patterns that are important on an ECG. So let's get the spotlight up here. When we look at lead 1, for example, we can see that the QRS complex is upright and the T-wave is upright, and that's what we should see in most leads. So you can see that that's the case in lead 1 here, in lead, oh, sorry, we've just gone on a little bit, in lead 2, in lead 3, lead AVF, it's the case. We can see that it's the case in lead V6, V5, V4, and V3, that we've got QRS upright and T-wave upright. There are a few areas where actually that isn't necessarily going to be the case, and it's important to know what the normal variants are. So lead 3 in this ECG has an upright T-wave, but actually in some ECGs it can be inverted. You can get an inverted T-wave and it's totally normal. That's just a normal variant. So that wouldn't be a sign of acute ischemia if you just have T inversion in 3 and AVF is normal. If both are deeply inverted, you might say that's abnormal, but T inversion in 3 is okay. The other areas where it's okay are in AVR, where everything is upside down. So you normally get a QRS complex that's facing the wrong way around and a T-wave that's completely inverted. That's totally normal. The same goes in V1, because again, these two leads, they're really looking at the right side of the heart, and that's why they're kind of upside down. So you see an inverted T-wave in lead V1. Sometimes it's pretty shallow and maybe a little bit inverted in V2, but certainly by the time you get to V3, you're starting to see those T-waves upright. But V1 and AVR, it's commonly inverted, and that's a normal variant. Everywhere else, really, we're looking to see upright T-waves. So that's how we interpret for T-wave inversion. If you see abnormal T-wave inversion, that's significant for the heart score. What about ST depression? Well, ST depression is pretty easy because it's just like looking for ST elevation, but it's the other way around. And I've got a number of cases that show abnormal patterns of ST depression. You don't really see any ST depression on a normal ECG. Pretty much you see that the baseline matches up with the ST segment. We normally measure the baseline from the TP segment. So after the T wave up to the next P wave, that's our baseline. You can see it wanders a little bit here, but if you imagined a line connected, ignoring the T wave, if there was a line going across and a T wave didn't happen here, you'd see it be on the same level in AVF here. And you can see the same thing in lead 3. And that's normal. If, of course, this baseline goes down, that's ST depression. So let's look through some cases. So here we've got another 12-lead ECG. On this one, what you can see, particularly, let's hone in on the particular abnormalities. AVL. Let's look at AVL. So look at the T wave. The T wave is inverted in AVL, and that's abnormal. We shouldn't normally see T wave inversion, certainly deep T wave inversion. It's a couple of millimeters or more. It's abnormal in AVL. What else do we see? Well, we see ST depression. So if you look at the baseline between the T wave and the P wave, it's about here, and you can see that this is below it here after the QRS complex. You've got ST depression in V6. See, it's down here after the T wave, then we go back up. That's ST depression, and that's abnormal. So that would be a sign of acute ischemia. Again, here we see ST depression relative to this baseline. In V4, we see ST depression relative to this baseline here. So this is an abnormal ECG showing clear signs of acute ischemia, showing ST depression, and showing T wave inversion. This next ECG is similar. We can see some T wave inversion for sure in V5 and V6. It's mainly T wave inversion. There might be a little bit of ST depression in V6, but it's mainly T wave inversion in this ECG. AVF, lead 3, lead 2, they're all inverted. So clear signs of ECG ischemia on this one. So I would mark this as acute ischemia, T wave inversion. I'm not sure I'd mark ST depression. There's only a little bit of subtle ST depression in V6, but I'd probably mark it as no for ST depression. Here we've got another ECG, and again on this one we see some T wave inversion too. It's shallow on this one, it's only a millimeter or two, and it's in V4 and V5. Those leads should be upright, and it's not, so that's T wave inversion. Interestingly, on this one, you can see that the T wave is upright in lead V1, and in fact, that's an abnormal finding in itself. You could say that that's an inverted T wave because it's supposed to be the other way around in V1. Next, you've got a grossly abnormal ECG. You can see clear ST depression in V6 and V5. Here's the baseline. ST segment way below it. You see how it slopes down into the T wave. That's particularly sinister when the ST depression slopes downwards. Sometimes, particularly with a fast heart rate, you'll see ST depression that goes in the other direction. It's sloping upwards. But down-sloping ST depression or horizontal ST depression, a bit more worrying. And this is quite deep as well. It's a good couple of millimeters. So quite concerning ST depression in these 3 leads. Looking at the anterior leads as well, we see concerning ST depression. When you see ST depression in V2 and V3, you've got to think it could be a posterior STEMI. Could well be. We might do some posterior leads in those circumstances, certainly in the ED, to see if it's a posterior STEMI, and we'll go for primary PCI. We've got ST depression in AVL with a big T wave inversion. And really importantly on this one, when you see ST depression in AVL, remember to look very carefully at the inferior leads because it could be reciprocal ST depression from a STEMI. And what you see in these inferior leads is big peaked T waves. Now on this ECG, it's not really enough to activate primary PCI because we've not got a millimeter of ST elevation here. But those big peaked T waves really suggest to me that this is an evolving inferior STEMI, and that when we repeat the ECG, we're highly likely to see that evolve into ST elevation. And indeed, that's what did happen in this case. So if you've got ST depression in AVL, look carefully at those inferior leads to really scrutinize and see if that might be an inferior STEMI. Next ECG again shows these lateral leads have got some ST depression. I think there's some subtle ST depression here. Look at this baseline, it's up here. What can we do? Can we draw a line? We can draw a line. Let's have a look. If we draw a line along the baseline, there, you can see that the ST segment is way below it. And again, way below it in V5. So we've got ST segment depression. If you're not sure about that in the field, you can always get a straight edge of some paper, put it across the baseline and have a look at where the ST segment is. And you'll be able to see, as in this instance, that there is clear ST depression. So that would be acute ischemia and ST depression. Next. Let's try and clear those annotations. There we go. So what have we got on this ECG? Now then, look at this. Grossly abnormal inferior leads. Deep T-wave inversion. Little bit of ST depression too in these leads. Now when you see that just in the inferior leads, it's got to make you think, actually that again could be reciprocal changes from a STEMI. It might not be just inferior ischemia. And indeed, that's what we find here. So the first place I'd look after seeing this is to AVL, because if you've got a STEMI and these are reciprocal changes in the inferior leads, it's often what we call a high lateral STEMI. And so that affects leads 1 and AVL, the high lateral leads. And you can definitely see in lead AVL, once again, we have got ST elevation. So let's just mark that on. Not done that terribly well there. Let's do that again on this lead. ST elevation. That's a high lateral STEMI, and that needs urgent reperfusion. So it depends on your local criteria, but that would warrant activation of the cath lab. It's a STEMI. Those patients, if we're sure that it's a STEMI, we won't include them in the PRESTO study. If we're not sure, and we're going to take them to the ED, but not the cath lab, it's fine for them to be in the PRESTO study, but I'd mark that as acute ischemia. So let's clear the annotations again, and let's move on. Get my spotlight back and move on. Now then, here we've got a different ECG. This time we've got broad complexes. So if we look at the rhythm strip, we can see that it's normal sinus rhythm because we've got a P wave, a QRS, and a T. P wave, QRS, and T. It's sinus rhythm, but there's a broad complex. The QRS complex is more than 3 millimeters wide. So when you've got that, you've got normal sinus rhythm, every beat's conducting, you've got to think, why is the complex broad? And there could be different reasons. It could be because the patient's got an electrolyte abnormality, but the most common is a bundle branch block. And it's going to be left bundle branch block or right bundle branch block. We've just got to decide which one it is. Now, you may have all sorts of different ways of looking at deciding whether it's left or right bundle branch block. My way is simply to look at V1. It's very simple. In left bundle branch block, what we'll see is this, that after the P wave, we get a deep, deep S wave, and then we get ST elevation and a big T wave. That's left bundle branch block. Right bundle branch block doesn't look like that. It has an R wave first, and then an S wave, and then an R wave, like an M. This is left bundle branch block because it goes straight down. Now, in left bundle branch block, you will always get ST elevation when the QRS complex is going mainly down. So it goes in, the ST segment basically goes in the opposite direction to the QRS complex. See? There's ST elevation when there's a downward QRS complex. And when there's an upright QRS complex, we get ST depression. That's normal. That's appropriate discordance. What we shouldn't see is a downgoing QRS complex and ST depression, or an upgoing QRS complex and ST elevation. If we see that kind of concordance, then it's highly specific for a STEMI. And in this patient with left bundle branch block, we see exactly that. Look at V3. Let's annotate this with a drawing again. So let's have a line. Here's the reference baseline, goes across here. And what you can see is we have got ST depression. And the QRS complex is going mainly down. So that's a specific sign of a STEMI. So we don't necessarily take those to the cath lab because those aren't agreed protocols, but that would be a clear sign of acute ischemia. If you're not taking the patient to the cath lab, they can be in the PRESTO study, but that's a sign of an acute ischemia. And you know what? Left bundle branch block, even without that, it's a bit, it's up for debate about whether you'd call that acute ischemia. Deliberately left a little bit subjective. In the PRESTO study, if there's left bundle branch block, we want to know about it. We'll call that ischemia. We'll say that that's not a normal ECG, and we'll say that sort of patient with chest pain should not be left at home. So we want to know about left bundle branch block. What's next? This one, right bundle branch block. So here we've got another ECG showing sinus rhythm, but we've got a broad QRS complex. It's more than 3 small squares. And we know it's right bundle branch block because we don't have the deep QRS complex going down and then ST elevation. We've got something else. In this case, it's just going down a little bit and then up. Anything other than that left bundle branch block pattern is right bundle branch block, and that's what this is. Now, right bundle branch block, not necessarily a sign of ischemia. In the PRESTO study, we ask you to record whether the ECG is normal, and if it's not, then we'll class it essentially as potentially we'd transfer that patient to the hospital anyway. It's not necessarily ischemic with right bundle branch block. It's often a normal variant, but we want to know about right bundle branch block. And one thing you'll notice in right bundle branch block, you normally get T inversion in these anterior leads. That's normal. It's not actually ischemia when you see that. You'll usually get that with right bundle branch block. But apart from that, you'll see the ST segments are usually on a level. everywhere else. You don't get the ST elevation and ST depression like you do with left bundle branch block. What have we got next? Aha, really interesting ECG pattern. So what I want you to focus on here is leads V1 to V3. So what can we see here? Let's just circle those there. V2 and V3. What you can see here is a biphasic T wave. So it's going up and then it's going down and then it's returning to the baseline. It's going up, it's going down, then it returns to the baseline. Not quite enough ST elevation to call this a STEMI, but there's definite T wave inversion. So you could click yes for T inversion, it's yes for ischemia. And this is what we call Wellens syndrome. Wellens syndrome occurs when you get a very tight stenosis in usually the left anterior descending coronary artery. It's a really important one to spot. Often the patients do have an MI with Wellens syndrome, the troponins will be high, and often they go on to develop an anterior STEMI afterwards. So really important diagnosis to spot. That is about all we've got for today. So I hope that's been useful. It's a quick rundown of how we assess the ECG for ischemia. If you have any questions, please do just get in touch. Thank you very much.